This is a very special time of the year, so I'm very happy to be here with all of you. There's a lot of you, so I hope this session is going to be helpful for you. Today, I've been asked to talk about managing peripheral neuropathy, and as Munira was saying, it's a symptom that bothers many, many patients. So hopefully this will help all of us understand what is peripheral neuropathy, why does it matter, why is it so important, and why does it occur, what are the causes of peripheral neuropathy, and what can help with managing the symptom. And at the end, we'll have some time to have your questions as well. So peripheral neuropathy is really a damage to your peripheral nerves. Peripheral nerves are part of your body, your nervous system, so your sensation and your motor system, that is outside of your brain and your spinal cord. So anything in the rest of your body, basically. And it can show up in different ways because the nervous system actually controls different parts of our body. So the first function is sensory, so sensation. And then the second part is motor, so our movement. And finally, autonomic function. So autonomic are things that are happening in the background without us knowing, like keeping our blood pressure going, keeping our bowels, our digestive system going. So when peripheral neuropathy happens, it can affect all three of these areas. In terms of the sensory issues, patients can experience numbness, meaning the sensation is decreased. It doesn't feel, or it could feel strange with tingling or prickly sensation, like pins and needles. It can also feel like burning or cold, even though the temperature isn't burning or cold or freezing to you. So changes in the temperature sensation. As well, you can feel difference in in the vibration or position that your body normally is in. The fancy word is proprioception, but basically what it means is when you're walking or when you're touching or holding something, it doesn't feel normal. So it leads to problem with your walking or with your balance. Other patients have told us that it feels like itching or gnawing, like bugs under their skin. And other times, touches that normally wouldn't cause discomfort can be quite uncomfortable. We call that allodynia. So things like putting on your clothes or putting your feet into the bed where the sheets are touching can feel like pain or burning, and that's abnormal. The next big word is paresthesia, and that's something that happens sort of out of the blue. These strange sensations, any of the above, the tingling, the prickling, the hot and the cold, and the itching, can just happen out of the blue even without you doing anything, and that's paresthesia. And finally, pain. The big word may be neuropathic pain, just very specifically saying that the pain comes from the nerve damage. So that's a lot of symptoms or sensations that patients can experience when they have peripheral neuropathy affecting the sensory part. In terms of motor function, though, you can feel weak when you move or use your muscles. You can have gait, meaning when you walk, you can have problem with that. You can have balance disturbances, which can lead to falls. There can be difficulty with a lot of different motor skills, and we'll go into some examples later on. And finally, people have even experienced what we call wrist or foot drop, where your hand and your foot drags and it doesn't stay in the normal position. So again, causes problem with your balance and your walk or your daily function when you try to use your hands and your arms. And then finally, the third category with autonomic function, patients can experience disturbances in the bowels with constipation or diarrhea. They can have urinary dysfunction, sexual dysfunction, or what we call orthostatic hypotension, meaning when they try to sit up or stand up, the blood pressure drops and they feel a bit woozy, they feel lightheaded, again leading to increased risk of falls. And finally, people can have abnormal sweating as well. So just basically anything that our body normally does in the background, it's out of whack. And because of that, it's a big problem. As Munira was saying, a lot of patients do have peripheral neuropathy. In fact, it is called the most common non-hematological side effects of chemotherapy or treatments. So we know that chemotherapy, for example, would drop people's blood count, and that's one big group of side effects. But outside of that, peripheral neuropathy is the other big side effect that patients experience and complain about. Specifically to the myeloma patients, almost just over half of them will have the peripheral neuropathy either when they were first diagnosed with myeloma or while they're going through the treatment. So that's a lot of people. If we think about the number of people sitting in this room, if they're all going through treatment, half of them can have problems with everything that we talked about in the last slide. And the important issue, though, is because of the neuropathy, it may limit how much a patient can get in terms of their treatment, either because it's too uncomfortable for them to continue, or that the dose have to be decreased or adjusted. And just as importantly, it can affect the function of the person. So, for example, it can affect the fine motor skill of a person. So fine motor skills being things that you do mostly with your hands, like doing up your buttons, like writing or picking up objects with your hand. Also gross motor function, like using the big muscles in the body, walking, or just sort of sitting up or getting up. Those big muscles in the body can be affected. And if you can't do these things for yourself, that sometimes means you need a lot of assistance. It changes how you live day to day. It may even make you require a lot of support service, affects people's independence and obviously their mood. All of that obviously can affect the person's quality of life. If you're not able to live and do the things that you like to do, you want to do, your quality of life will suffer. And because of all the problems we talked about, and the patients or the families have to go through, obviously increases the healthcare costs to the person and to the system. So how does it happen? Why do patients experience peripheral neuropathy? Well, it could be a direct result of just having multiple myeloma as a disease. And some of the research literature says anywhere between 2 to 20% of patients with myeloma have peripheral neuropathy just from having the disease. But also it can happen when there are physical damages to the nerves. And it could be a result of surgery, radiation, or even plasmacytoma. So as many of you know, plasmacytomas are tumors as a result of the abnormal myeloma cells. So when the tumor invades into where the nerves are, it can cause damage. Sometimes the treatment for the plasmacytoma is radiation, and radiation in itself can also cause damage to the nerves. Other times people have pre-existing peripheral neuropathy even before the myeloma diagnosis from another medical problem, such as diabetes, because we know that the high blood sugar damages the nerves over time. People who have shingles infections, the virus also damages the nerves. People who unfortunately have issue with alcohol abuse can also have peripheral neuropathy. And finally, there are some types of vitamin deficiency that can also cause peripheral neuropathy. In terms of the cancer group as well, there's a special syndrome called Paraneoplastic Syndrome. And that's when your cancer secretes these substances in your body that sort of make the normal function of the body go out of whack. And one way it shows up is creating peripheral neuropathy. It affects or damages the nervous system in a way that shows up like peripheral neuropathy with the pain and the tingling and the motor problems. And then of course many of you are already familiar that the treatments you receive for multiple myeloma can cause peripheral neuropathy as a side effect. The big ones are thalidomide and pertuzumab. Lenalidomide and the newer agent, carfilzomib, these tend to not have as often the issue with peripheral neuropathy, or even if it occurs, they tend to be very mild. So for today, I'll just focus on thalidomide and pertuzumab when we talk about how these medications can cause peripheral neuropathy. So this is a table on pertuzumab looking at how the peripheral neuropathy affects the sensory, the motor, and the autonomic functions. So in terms of sensory issue, pertuzumab can cause mild to moderate sensory loss, usually the same on both sides, so symmetrical, and what we would call in the distal part or the lower part of the body, so the lower limbs. And they tend to happen from sort of the toes up. Some people actually have pain as a result of the sensory loss, the neuropathic pain we mentioned, and also that strange sensation, the paresthesia, that can come on without warning. In terms of motor deficit, it's occasional, so it's not a usual thing, but people can experience mild weakness in, again, the lower extremities or the distal part, so in the arms and the legs. Now, with regards to autonomic problem, again, it's quite occasional, but people have been known to have that low blood pressure when they try to sit up or get up. They can have disturbances with the digestive system, so they can have either diarrhea or constipation. Now, when would this problem occur when people start getting treatment with bertuzumab? Typically, it's dependent on how much you get. So the more bertuzumab you get over time, so the accumulative amount, the more likely you'll have the neuropathy. And in terms of the research, it's been demonstrated, typically it happens after the 5th cycle, but it then sort of stabilizes by the 8th cycle. So it gets worse as you get more, but then it doesn't get any worse beyond that 8th cycle. Now, the important thing for a lot of people, though, is, once I'm done with my treatment, will it go away? And the good news is it usually is reversible and it will go away for most people within 3 to 4 months. In some research, it says up to 60% of patients see that the neuropathy goes away in an average of 5.5 to 6 months. There are, unfortunately, some people who takes longer, even beyond a year, for the neuropathy to go away, and some people find that it never goes away completely. It may get better, and it will get to a milder stage, but it doesn't go away completely for some people. So that's how neuropathy happens with bertuzumab. And then with thalidomide, you see that there are fewer issues. The table is a little bit shorter. In terms of the sensory problems from thalidomide, it can again be mild to moderate sensory loss, and again is symmetrical on both sides of the body. With the motor problem, people can have weakness, but also tremors and maybe muscle cramps, which of course can be quite uncomfortable and frustrating. And in terms of autonomic issue, mostly just with constipation. Now, in terms of thalidomide, it seems the dose matters, but also how long you've been on the treatment matters, which is why there are some recommendations to say, try to limit how long a patient gets thalidomide for, probably not more than 6 months, just so the neuropathy doesn't get so bad that it's irreversible. And most people find that if it's mild, if the neuropathy is not very bad to begin with, it tends to go away completely very quickly, within like 3 weeks. Of course, if it's more advanced, if it's more significant, the pain or the discomfort is worse overall, it will take longer to go away. And again, some people find that it doesn't go away completely. So the question was, what are the factors that affect how quickly the neuropathy goes away? Could it be that if a person has other underlying medical problems such as diabetes, which could just come on its own, or it could be related to as a side effect from other treatments, even treatment part of myeloma treatment such as the steroid that one can get? And that's a very good question. There's not a definite research to say yes or no. But I think the general feeling is, for sure, if a person has a pre-existing problem with the neuropathy before they started myeloma treatment or being diagnosed with myeloma, it's more than likely that that's contributing somewhat, and that in itself perhaps will affect whether the problem will go away completely. Because if you have a separate problem that continues to irritate or damage the nerves, it is, I think, understandable, even once your treatment for myeloma is done, that the neuropathy can continue, or at least even if it gets better, it won't go completely away. So that's a very valid concern there. So the bigger question then is, what will help with the peripheral neuropathy? How can we help it go away faster, or so that it goes away and doesn't come back? The important thing is, again, we know that there are these strange sensations in terms of temperature. People can feel either overly hot or overly cold, and that also means the patient's sensation or interpretation of the temperature of an object or the outside weather isn't always reliable. So we want to make sure that we avoid injury to the skin, because you can't tell what the temperature is. And that's why the suggestion is, when you're going out, make sure you cover your hand and the feet, especially in this time of the year, in the winter months. Make sure you wear mittens and put on a hat, everything else to make sure you stay warm. And if you're handling things from the fridge, it's better to use a oven mitt or something that acts as an insulation. Or if you're cooking, you're working on the stovetop, you're picking up something from the oven, again, make sure you protect yourself, use oven mitts and things like that. Even simpler things that we don't always think about, like washing dishes or doing gardening, the Canadian Cancer Society recommends using gloves just to, again, protect the skin. And really good hand and foot care, looking after the skin so that it doesn't get dry, doesn't get cracked, and moisturize aggressively, and again, avoid doing things that would irritate or be abrasive to the skin surface. So again, doing dishes, for example, make sure you put on gloves so that the water and the detergent doesn't get to the surface of the skin directly. The next big thing is preventing falls. As we said, the sensation can be affected, where you are in space with your feet, or when you're using your muscle, if you have weakness or tremors or cramps, that can also affect how you walk, and that really puts people at higher risk. So we need to look at removing any tripping hazards around the home, simple things like making sure the lighting is adequate at home, clearing a pathway, in the tubs or in the bathroom, make sure you have those non-slip mats. And finally, wearing proper footwear. Sometimes the biggest problem we notice are people wearing just socks when they go around in home or in the hospital, and that's unfortunately quite dangerous because you can slip very easily. Or if you wear shoes that are not really fitted well, that can also be a problem, especially with stairs and things like that, or going up or down an incline. Other things that people have found very helpful are what we call rehabilitation. As we said, muscle weakness or tremors or cramps, those can cause problems. And this is where you may need a specialist to help, to guide you in terms of retraining about balance and gait, how you walk. And this is where physiotherapists and occupational therapists could be quite helpful. They talk about gait aids. Some people may need canes, special types of canes. I see a few of you using canes. Other people may need walkers. Again, footwears and things like that. This is where the physio and occupational therapists can also give advice. Looking at the home environment as well. The occupational therapist specializes in that, looking at what things you have to do around home and make suggestions that what modifications need to be made so that the tripping hazards decrease to the minimum and that you can still be independent but safe at the same time. And the aim overall is, again, to prevent falls and also making sure that people can adapt and still do the activities that they need to do or want to do without aggravating the peripheral neuropathy or without letting the neuropathy come in the way of doing things that they want to do. And because of the muscle weakness that some patients can experience, it has been recommended to go into exercise programs. It could be aerobic exercise where you build up sort of the general endurance or stamina of the body, but could also be resistance exercise where you focus on the strength of a specific muscle group. Now, having all these symptoms of discomfort can be quite trying for one's mind and spirits. And this is where something like mindfulness could be helpful. It helps people cope a bit better when they're dealing with these symptoms day to day or these limitations day to day. And again, this is where the occupational therapist could be helpful. Some of the occupational therapists in the hospital are experts in teaching mindfulness and relaxation techniques. And again, they help you with the environmental planning. Now, I'm sure a lot of you are wondering about this particular treatment option, acupuncture, because if the problem is damages or irritation to the nerves, wouldn't stimulating the nerves help? And that sort of makes sense, and that's why acupuncture is used quite frequently as a treatment for peripheral neuropathy. The unfortunate thing right now is there isn't enough scientific research to say it works great. Having said that, I think most of the experts feel there are minimal side effects or harms, so it's probably okay to go ahead with it. But of course, you would probably have to listen to your body. If you go through a treatment session and you feel like it made your symptom worse, then it's best to maybe avoid that or discuss with the massage therapist if there's a different type of intervention, different type of treatment that they can use that wouldn't make you feel worse. Other things that people wondered about are nutritional supplements. There are actually many, many different supplements that people wondered about. It could be, extracts from plants, it could be vitamins or minerals. The bottom line though is if you have a very specific deficiency and that is something advised by your doctor, then it would be helpful to do the supplementation. But otherwise, there's not enough research to say it would make a difference or even be of benefit. And finally, of course, beyond the things that you can do to help yourself, this is where talking with your physician and nurses could be important. Sometimes the symptoms are so significant that maybe you require medications. Now, the one thing I want to note is from the American Society of Clinical Oncology, they mentioned that there isn't one medication that's been found to be helpful as a prevention. So a lot of the medications that I've listed here are used for treatments only. People have certainly thought about using them as a prevention. You know, knowing that the treatments will cause the neuropathy, when it makes sense to try some of these medications up front to prevent the neuropathy from happening altogether. The unfortunate thing is there isn't enough research to say that these medications work in that way. So all the things that we want to do to prevent neuropathy are probably the things we talked about earlier with the falls prevention, protecting the skin from temperature damage, etc. But no medications or supplements can actually work effectively as a prevention. They are, however, sometimes quite helpful as a treatment. And there are different types of or families of medications here. I'm deliberately vague in naming the medications just because it's something that you need to speak to your individual physician and nurses about. Every person's situation is different. You may have other underlying medical problems that would need to be taken into consideration when your doctor, nurses, and pharmacists suggest medications. So just broadly then, the first group of medication we may use for peripheral neuropathy is anticonvulsants, because they work in sort of the nervous system in decreasing the irritation to the nerves. The second family is antidepressants, and there are two different types of antidepressants broadly that we use. And again, it's the same idea that they've been shown to help decrease the excitation or irritation to the nerves, and that's how it helps with the symptoms or discomfort patients experience. And finally, if those two groups of medications aren't enough, sometimes people find they have to add opioids, meaning morphine family of medications. And as you know, there are many different types of morphine drugs in that big group. And a lot of people are rightfully concerned about if these medications can be used safely given that opioid crisis we have. And that is also, again, why you should speak to your individual physicians about if this is the right medication. There are times when the peripheral neuropathy only happens to a specific part of the body, and it may only happen from certain types of activity or triggers, as we call them. And if it's limited to a very small area, it may actually be reasonable to use what we call a local or topical applications, typically in the form of gels or creams, and they're really medicated creams or gels. And the typical recipe are the medications about the anticonvulsants, the antidepressants, or other things like local anesthetics, but just put into a gel or carrying agent where you can just apply directly onto the skin surface. And that could be helpful for some patients' peripheral neuropathy. Again, that really depends on your individual situation, and you need to speak to your doctor about that. And finally, this is really my last slide. I'm really going quick, Dave, huh? I just wanted to share with you some future direction I found when I was doing my preparation for this talk. In this day and age where a lot of the cancer treatments are sort of based on the individual's genetic or gene makeup, the thought is also, are there any predictors from our genes that would tell us if you're at higher risk for peripheral neuropathy? So people have looked at these different variations. We know that our gene is made up by these letters, these different proteins, and how the proteins sort of string together has a different function on our body. And there are sometimes these changes that may also affect how our body responds to chemotherapy, how likely you develop the peripheral neuropathy. So this is an interesting area that is obviously still in development. So a space to watch for, but obviously we need more research to tell us in the future, would we get to a point where we would be able to tell with this particular person how likely are they going to have peripheral neuropathy and what drugs will give them more problem with neuropathy, so thus to avoid those type of drugs. And with that, I'm just going to take a break now and have questions for you guys. Before I take the questions, just a disclaimer, because this is what is meant to be a public health information talk. So what I'm giving you is general information, so it doesn't all apply to your personal circumstances. And I think I'll try to refrain from discussing your personal medical conditions, because your doctors and your nurses know you the best. If anything that I say or advise doesn't completely line up with what your doctors are saying, always go with what your doctor is recommending. Yes, certainly in terms of types of symptoms that patients have been known to experience, would spasm be one of them? I think yes, it can certainly happen, and it would be under the category of motor peripheral neuropathy. Okay, so the question too is, can it happen more on one side than the other? And this gentleman mentioned he had a previous surgery that involved the blood vessels. I mean, yes, I can foresee how it could be a contributing factor. Difficult to say how much of it is due to that previous surgery, difficult to say how much is from the myeloma or the treatment. But if there is something specific that happened to the one side of the body, I think it's reasonable to say then maybe that's why you have more neuropathy or more symptoms on that side of the body versus the other. But in general, it does seem that the peripheral neuropathy from myeloma or the myeloma treatments tend to be symmetrical. Right, so I guess definitely pain can be a part of peripheral neuropathy, but in your particular question or circumstance, it's difficult to say whether that pain that came on was a result of neuropathy or a result of the medications that you were on, because I'm not going to go into what medications you're on, or if there's any other things that happen to that part of the body, like a prosthesis or other things. But the thing about peripheral neuropathy is it's damage to the nerves, and it could be a physical damage, it could be a chemical damage from drugs and things like that. So probably many things play a part and come together contributing to the final problem. And during the break I was talking to some of you who expressed your frustration that the neuropathy is quite debilitating and limiting, and even though they're on medications, even on good doses of medication, the problem doesn't seem to get better quickly enough or doesn't go away. And that may be why, is because there's so many different things that can contribute to how your neuropathy develop. And if it's not getting better, I think it is important you do revisit this with your team. Again, sitting down as to what are the potential causes, because maybe with each cause or each problem, there's a different fix to it. And it may not just be that cookie cutter approach. The two questions, I'll take the second question first because it's easier, and that being, can we defer the onset or the occurring of peripheral neuropathy by being physically active? I think from the current research and guidelines, it doesn't say that there are anything specific that one can do to prevent the neuropathy from coming on. No medications or supplements or even exercise will do that, it seems. Having said that, there's obviously no real harm or downside to doing physical activity as long as you sort of work within the limits of your body, of your stamina, of what you can do, and not go so hard that you injure yourself. Whether or not it will give you that desired result of preventing the neuropathy, I would think not. The first question then was, I think this gentleman was noticing some forgetfulness and misspelling of words as he's continuing with treatment. I think that's a different phenomenon and not a peripheral neuropathy, because remember, peripheral neuropathy affects nerves outside of your brain and your spinal cord, so in the outside part of the body, and it usually is the sensation or the motor skill or motor function of the body, or blood pressure and bowel and those sort of background function. So what you're describing is actually a central problem, right? With the brain being the main organ that does the work on memory and on coming up with the right words and expressing yourself. Now, I don't know your full circumstance, so I'm not going to hazard a guess or diagnosis, but I'm wondering if what you're saying is a common side effect that patients experience when they're on treatment called chemo brain. Right, chemo or treatments does affect the brain's ability in terms of memory, in terms of planning, in terms of expressing yourself, etc. So that's different from peripheral neuropathy, and unfortunately not in the scope of today's talk. The thing about the chemo brain, if this is what it is, most time it gets better as you stop the treatment, as you come off the treatment, just like the peripheral neuropathy, because you're getting away from the offending problem here. Yeah. So the question is, because I mentioned that lenalidomide doesn't carry the same frequency of peripheral neuropathy, or that even if it happens, it tends to be much milder, when would patients get thalidomide? That seems to be a problem here. And I'm not a hematologist, so I'm not going to be the expert here to give you the right answer. So I unfortunately have to defer that question. From my reading, I think thalidomide is a sort of a treatment afterwards, right? But I would encourage you to speak to your doctor. The good news is, I guess, if you don't need the thalidomide, then that's great. There's a lower chance of peripheral neuropathy. So the question is, for some people, they notice that one drug alone isn't enough, and they may need to take a combination of medications. So the question was, how do these medications work? So the Lyrica, that's the brand name, or the generic name is pregabalin, is an anticonvulsant, similar to gabapentin, another medication in that family. So what they do is they basically changes the body's threshold to excitation. So the nerves basically don't get excited about the injury so quickly, and that's how it helps with pain. The other medication the lady mentioned, Cymbalta, or the generic name Duloxetine, is an antidepressant, and that's this one. The Serotonin Norepinephrine Reuptake Inhibitor, SNRI, quite a mouthful. But basically what it's saying is this particular antidepressant blocks the action of these two pathways, the serotonin and the norepinephrine, which contribute to sort of your pain sensation. So that's how it helps with neuropathy, or pain relating to neuropathy. So they work on different parts of the body's perception of pain, basically. Pain is a very complex phenomenon. The more we study it, the more we realize how little we actually know about it. Pain happens because of many different things happening between the body part that is dealing with the injury and the processing unit, the organ, the brain. And because there's such a long pathway in between the signal going up and the signal going back down, there's so many different things that can come into play. And these medications, the different classes of medications, try to target the different signals or the different pathways. The pain gets sent up to the brain, and how the brain tells the body to react. So that's sort of an overgeneralization, but that's really the bottom line of how a lot of these medications work. Same thing with the morphine family, the opioids as well. Opioids work on these chemical signals in the body that, again, sort of tells the brain, oh, don't get so excited about pain in general. But they work sometimes on different types of pain. So more frequently is used for bony pain or soft tissue pain, although they can still be helpful for neuropathic pain, which is why it's still on the list there. But unfortunately, for some people, they really do find they need that combination. And it's about finding the right drug, the right medication, as well as the right doses of each of those medications to find that one plan that works well for you. It's about balancing how well it helps with the pain or the discomfort, but also what side effects you may experience, right? Because you don't want too many side effects either, so it's a trade-off. And this is where it may be a bit of that trial and error process. So as you were saying in the beginning, you were only on 2 medications, and then later on you have to add a third, and that's because the pain seems to be not adequately controlled. There are also times where pain can change over time, right? Because the way the brain deals with pain also changes over time. And this is why people with chronic pain has a different type of issue compared to people with acute pain. And that really just, again, speaks to the complexity of pain in general. So don't feel discouraged if you find that the medication that you're on right now doesn't seem to be adequately controlling your discomfort. Definitely go back to your team, to your nurses and doctors, and say, hey, this is what I've noticed. It might have gotten better, it might have not. And this is also where you can help the team out by keeping a good pain diary, as we call it. You know, when does the pain actually occur, or any discomfort occurs? Is there any triggers, anything that brings it on? Anything else that I do will make it better? And if I do take a medication, how quickly does it kick in? How long does the relief last me? And are there any side effects? All that information, when you bring it back to your team, will really help them figure out what is the best way to approach your discomfort. So the question and the comment, the first comment was the neuropathy didn't come on initially right at the beginning, and although sometimes we are told that this may happen, to expect this as a side effect potentially, we may forget, or hoping not to have that problem, right? So I think that highlights the importance of careful monitoring and sort of assessing from the team's perspective. This is what your team owes to you, right? The doctors and nurses, we should do our part in checking with you guys when you come in for your treatment reassessment. How are things with you? Are you experiencing any symptoms that are suggestive of neuropathy, so we can act sooner? And then from your perspective, definitely the falls preventions, the good skin care, etc., are something that you can do to help yourself with, so that we try to prevent the problem from getting too out of hand. With regards to your question as to whether the biological agents like bortezomib brings more risk of peripheral neuropathy, I think just from the nature of that question earlier, that we don't use thalidomide as often now compared to bortezomib, that alone will cause more people to have peripheral neuropathy. Having said that, you also made sort of a mention of some of these trial medications can have side effects. I think that's another thing too. Treatments are always evolving, and the longer we have a treatment on board, the more we find out about how it affects people. So maybe for now, bortezomib we know causes problem, and then the new agents like carfilzomib, which is also a biological, doesn't seem to have that same problem with peripheral neuropathy as often or severe, but maybe down the road we'll learn more about it, and then we'll change our sort of comments about it too. And then same thing with the clinical trials medications. There are investigational agents right now, so there's not enough that we know about them. But maybe in the future, once we have more experience from our patients, we can then make a recommendation and say, well, maybe this particular agent can also cause peripheral neuropathy in these type of circumstances, and that's how we can work to minimize or prevent them or get on treatment as soon as they occur. Okay. Revlimid was commented early on with as being lenalidomide doesn't carry the same amount of risk. So actually, when I look it up in the literature, there hasn't been any comment specifically about what percentage of patient develops neuropathy, because it just doesn't happen much. I think with being in the same family as thalidomide, they made a comment that it's the dose and the duration of being on that treatment matters. So, I'm wondering, now this is not confirmed, but I'm wondering, does it matter as well how long the person's been on lenalidomide for, what dose they were given, would it matter? But as far as we know so far, it doesn't seem to be a common occurrence, so hard to say what the overall statistics is. I can look into that and get back to Dave if it's helpful to the group. Yeah. I'm not sure if maybe I'll call on the expert in the audience, Alan, if you know. So the expert, Ellen, I think very helpfully pointed out that it depends on what types of drugs they received in the past as well. If there are other drugs they received, like the thalidomide, that can actually cause problem with peripheral neuropathy, maybe that also changes the likelihood of you experiencing neuropathy on lenalidomide. Again, as we said, there are patients who have peripheral neuropathy just by having myeloma alone. So some of it could be the myeloma itself and not really a medication or treatment related neuropathy. And that's a problem too. That's why in terms of the research, it's very difficult to pinpoint a number sometimes, because there are just so many factors here, and it's very hard to tease out how much of each reason is contributing. And of course, the more treatment options there are now and the longer people live with myeloma, there will be these people who've been through so many treatments. So then the body is sort of primed, and it's difficult to say then. I will make that comment when I read about bortezomib. It seems to say that even if a person had bortezomib in the past and then got back on it, there is a low risk, a relatively low risk of having peripheral neuropathy. So I guess that's somewhat reassuring that even if you have to get back on the bortezomib, it seems that the risk of having neuropathy, because this is your second go around, isn't very high. Again, I think with time we'll know more. So the question is, what is our opinion on medical cannabis for peripheral neuropathy? And I think that got a reaction from the audience. I'm sure many people are wondering, just haven't asked so far. And in fact, we have had a lot of interest in that question in the last year or two from all the patients that come to our clinic, not just for peripheral neuropathy, but just for cancer pain in general and several other symptoms. The bottom line is right now, there isn't enough good quality research on cannabis for us to say what to think of it. The research that's been done so far had actually been on a pharmaceutical equivalent. So it was maybe what you would say a copy of the active ingredient from the marijuana plant. So it's not exactly the same as what you can get when you use the marijuana product. And also we know now there are so many different types of products, right? You can smoke it, you can vaporize it, you can eat it, either fresh or dried leaves. You can have these oil or capsules. And much like a lot of the other natural products or health supplements, how you make the formulation probably matters in how it works. And unfortunately, right now, we just don't have that information to say, you know, number one, if cannabis is helpful for neuropathy or cancer pain, and if so, what formulation works the best? And then thirdly, what dose is the most helpful? And finally, which type of patient will find it work the most or the best for them? So a lot of questions that have not been answered just at this point. The good news is now that it's been sort of legalized and there's a big interest in it, there will be high quality, bigger research studies done on the actual cannabis products. And these will be become available to us, the findings will become available to us maybe in the next 5 to 10 years. So something to watch for. I will tell you our clinical experience when our patients are very motivated to try it and we help them get the product, it has been somewhat underwhelming in that it didn't help to take away the neuropathy or the pain completely. It does help somewhat for some people. So I think that's the thing. Not everybody find it helpful, and those who find it helpful to a certain degree. Not to the point where they can come off of all the other medications, or they can come back to say, this is the best thing that happened in my life. So not there yet, but I think with time we'll know more about it. According to the Canadian guidelines, based on consensus from experts, right now the recommendation is we would only consider cannabis as a third or fourth choice, and certainly not by itself. It would need to be used with other prescription medications that we know work better. And if we were to use it, the suggestion is to use the pharmaceutical equivalent, so a prescription pill, rather than the cannabis product, because we don't know which product works and how it should be given. That is to say, though, we of course will still help patients who are interested in learning more about it. What we typically do is refer them to a cannabis clinic where they have these educators that would talk about the different products. The thing, of course, to note as a consumer is it is a booming industry, and these providers and producers are here to make a profit. So they will share with you the products available to you. Whether or not you want to use all of those different products recommended or pay that amount for that product, I think you need to use your discretion as a consumer. In terms of a health information or health advice perspective, it's a bit of a question mark is the bottom line. So I think that the comment was, there are people who use formulations where it doesn't make them feel stoned or drowsy or fuzzy, and maybe that's where we should be focusing. The thing though is that comment is based on that there are two active ingredients from the cannabis plant, as a lot of the audience member already knows, THC and CBD. THC is the one that so far, as much as we know, seems to be the one helpful, responsible for pain management, but it's also the one that acts on your central nervous system, on your brain. So that's where all those side effects like drowsiness, feeling high or feeling fuzzy come from. So unfortunately, it's a package deal at this point. If you want good pain relief, you're probably going to get some of those side effects. If you go with the CBD that does not make people feel high or drowsy or dopey, it's only been sort of looked at helpful in specific type of pain like spasmy pain from multiple sclerosis, certainly not in cancer or cancer-related neuropathy. So I think the expectations or the hopes are not really lining up right now with what's available in the market. And that's why I feel like we need a bit more time. Let the research develop first, and then we'll have better recommendations. So the question is more about in terms of which treatment is the best, especially in the context of minimizing the risk of peripheral neuropathy. Again, because I'm not a hematologist, I don't think it's my place to recommend a treatment over another. The comment made earlier is thalidomide doesn't get used as often these days, and if it is suggested, there must be a good reason for it. So I think it is very helpful to find out from your mom's hematologist why they would be particularly recommending thalidomide, for example, or something else. And it's, I think, reasonable to ask, if we're concerned about her risk of neuropathy because she already has diabetes, so perhaps a higher risk, what is the best agent, sort of balancing the benefit of controlling and treating the myeloma versus the potential side effects. So it's that trade-off. So the question was, are there any specific genetic tests that one can go for right now, particularly if I have some known hereditary issue, would that be important? The particular genetic test that I brought up here different from the genetic or hereditary problem that you were mentioning, so I don't think they have a direct relationship. The other thing too about the genetic sort of test they're doing right now, it's still in the very early phase. They're trying to find out these genetic variations, do they actually bring about more peripheral neuropathy and in which type of patients. So again, it's in very early stage, but just something as of interest for the group, that's all. So I would say as of now, the big consideration for someone who's just been diagnosed with multiple myeloma, thinking about their risk of peripheral neuropathy, is to, I guess, obviously have a good conversation with the medical team, the physicians and the nurses, going over the medical history, any other underlying medical problems, number one, going over the existing medications. Are there any medications that you're already on that can be a problem or contribute? And number three, the treatments being offered, what are the drugs and what sort of the likelihood of having neuropathy, and also the reason for recommending this regimen over another. And then I think finally, deciding what level of risk you feel the most comfortable with. Knowing though, as we mentioned, most of the peripheral neuropathy from treatment will go away gradually once you completed the treatment. So the good news is most people find that it doesn't bother them as much as in the beginning over time. And then yet other people find that the medications that they get put on is helpful to control the symptom or the severity enough that they can function. And I think that is an important point too, that we're able to manage the symptom even if it doesn't go away completely, but we can make it so in a way that it does not interfere with the things that you need to do or you want to do. And preserving function, as we call it, and maximizing quality of life, those are sort of the considerations here.
We'd like to thank you tremendously, Dr. Mak. What do you think of the presentation?